Okay. Hello, everyone. Welcome back to a new series of the Road to Venice 2026. We start with some interviews, and today I have the pleasure to have and host not just a KOL but also a friend. Welcome, Dr. Ruben Rodriguez Carval.
Good morning, Luca. It's my pleasure to be here with you again. Once again, one more year with
Thank you.
these Road to Venice interviews.
Thank you so much. I would start with a short introduction because probably two or three people in the world don't know you. So you are of
Don't think
course,
so. Don't think so.
a vascular endovascular specialist, and now you are medical director of IVEI, so Instituto Vascular y Endovascular Internacional in Marbella, Spain, and the director of the unit of angiology again in Marbella. Um, Ruben has an extensive experience in not just diagnosis, but especially in minimally invasive treatment, both on venous and arterial side, with a strong focus on the endovascular procedure. After his graduation and specialization in angiology and vascular and endovascular surgery, he had some time to spend for international training in high volume center, refining his expertise in the venous also complex cases such as deep vein thrombosis management and venous compression syndrome. And then he's also an active researcher, international speaker, and authors of scientific publication. And particularly, he also is one of the opinion leader in the new technology called high intensity focus ultrasound. So, welcome back, Ruben. And I will start with you with a question going back to your early path and your career. So,
Okay.
looking
First of
back,
all, thank you, Luca, for this kind and friendship basis presentation. Um, yeah, it has been a few times that I finished my career. And yeah, I think that the educational stuff is one thing to discuss. I think that you have a question for me about that. And yeah, we can discuss it. Okay, come on, let's start.
yeah, let's start. And so, not to make it spicy, but I would like to ask you, looking back at at your career, what, were the most decisive moments or mentors that shaped your professional direction? What was that moment in which you said, "Okay, I know my path. I know what I want to do." Um, do you have
Mm.
any,
Yeah.
story?
Well, I have many of them probably because I consider myself a lucky guy because one of the best things in my career that I had it has been my master's, starting with my dear Dr. Doblas. He was the vascular surgeon in chief in Toledo. That was the hospital where I performed my residence, my specialization in vascular surgery. And from him, I took this vision of innovation, always this interest to be in the pipeline of last technologies, but always considering the evidence-based medicine and walking through evidence that shows us safety and effectiveness for the techniques that we are engaging and we are starting, no, in our department. So it was really important for me to learn that, and especially one thing that it marked me a lot in my career regarding what means to be a surgeon. Look, so that's one thing that I would like to share with young colleagues, with the young surgeons, because unfortunately, you and me, we are starting to be not as young as we thought. But I think that for a surgeon, I mean, you can be a really good surgeon, but you're going to be a better surgeon when you know. I mean, you can be a good surgeon technically. You can have a really skills to do the procedures, but you're going to be a better surgeon when you know when to indicate these procedures. But you want to be the best surgeon that you can be when you know when you don't have to indicate these procedures. I think that this is probably the best topic that I learned from my dear Dr. Douglas. I send him a big hug because he's still alive, and I really love him a lot, still in contact. And other person that made me change my mind a little bit, it's I think you know him. It's Dr. Enrique Roche. Dr. Enrique Roche was a personality when I was doing my residence, with a really innovation view, living his career in a different way, a little bit outside of the system, always thinking a little bit outside of the toolbox. And I have been always see him like a mirror, and I think that we have similar spirits and similar ways to think and to interpret medicine and to interpret what is the best for patients. And I want to say these two persons, especially. Then it have been a lot of surgeons where I learned a lot. Dr. Antonio Orgaz from Toledo too, Dr. Forcuberta from Madrid, a lot of not even vascular surgeons, angiologists, from Blink, Peter Snyder, Andy Smith. Roberto Ferraresi, a lot of really innovating and passionate people that what I like from them is that you can feel looking them walk and looking them do their job, their presentations, their lectures, they are really passionate for what they do. And this is another thing, uh, uh, mm, another thing that I feel really, really represented with.
That okay, that's wonderful. You did uh you mentioned a lot of great names, so how can I not agree with you? Well, next question will be about be an entrepreneur like you are. You're not just a vascular surgeon. You are a director, of course, also of your own clinic. So, my question would be maybe two questions. Yeah, it's better. How did you approach this transition, between be from hospital-based practice to private-based practice? And what do you consider essential, like setting up in your clinic from an organizational or technical standpoint?
Well, two really good questions, Luca. I think that the transition from the hospital to the pure private activity that we are developing here in Nivea Marbella from 2021 is that I think that I felt the necessity to find a space where I can develop and I can practice the kind of medicine that I always would like to do. And you know that sometimes this is difficult in a hospital setup with a big department, with a lot of pressure from emergencies, a lot of pressure of waiting lists, for patients to be intervened, and especially because I would like to develop a little bit more my expertise in phlebology, and and even in big hospitals, it's a little bit difficult to find a place for all these wonderful pathology that for me is amazing uh, to um, to treat and to work with, but that as it represents not sometimes a life-threatening pathology. Uh, I mean, we can discuss obviously with DVT, with pulmonary embolism, but in essential, all this stuff is getting at least out of the management of vascular surgeons, even angiologists, in a hospital setup. And right now, I don't know how it's working in Italy, but in Spain, it's now practically talking about hospitals. This kind of pathologies, it's practically managed in basis for internal medicine doctors, or just medical doctors. And for me, it was a pity, and it was a field where I I want, and I felt that I would like to develop more, and yeah, I was trying to find a place. It was not easy to manage, because we have to recognize that our formation during our medical degree, it's absolutely focused in medicine, but not too much in management in medicine. So um, all these uh, economics, all this business management, that a little bit knowledge that you need to build your own clinic and to start growing and to start implanting marketing plans, staff programs, protocols. All these are things that we have to. I mean, I had to learn, on the way, and a little bit self didactic, self learning. So. I think it's a part important, because medicine in the actual life, in the modern world, it's absolutely changing in my opinion, for a hybrid model between public and private, and probably in a few years we'll have probably not too much difference between one on another. It depends on the countries, but I think that is the way to go, because if not, for the public system, is not sustainable anymore, and in the private setup, is not sustainable for patients, even for the reimbursement. So I think it's a big part, an essential part to do it. And if you do it, as you ask for the technical, you have to assume, and you have to take the risk that you have to invest, and you have to try to get at least the state of art of technology that you need to offer your patients the best possible treatments.
Okay, thank you so much for really extensive explanation, which I share completely, because also in Italy we have the same issue. So thank you for that. And now I would like to start talking about endovascular
Mm-hmm.
in the venous field, and you are a KOL on this, so it would be the spicy part of this interview. No, just kidding. Anyway, my question is, could you share with us your algorithm when you have a patient with acute, subacute deep vein thrombosis? How do you plan from the diagnosis to
Mm-hmm.
the decision making, and reanalyze and treat the patient?
Yeah, absolutely, absolutely. Well, I think that as everything in medical scenarios, Luca, we have to start from the beginning, and the beginning is the physical examination of the patient. It's to approach and to understand what kind of a scenario we have, and taking in care quite many variables, starting with the age of the patient, the concomitant pathology that she or he could have, starting for especially oncology, cancer pathologies. And then uh, uh, regarding the scenario, we have to decide if we are on time. I mean, first of all is to make a diagnosis, a pure diagnosis of the level of the thrombosis, where we are, and what we have to approach. And this start obviously for the physical examination and for an accurate ultrasound. And regarding the extension of the DVT, we will decide if the patient is candidate for any kind of interventional treatment. And obviously the evolution time of this DVT gonna take a big part in the decision making to decide to intervene at this point or not. In cases where we have clear that the patient is an acute patient, there is not in our algorithm there is not too much doubt that patients with iliofemoral vein occlusion should go for a mechanical or pharmacomechanical thrombectomy, and to guarantee the reopening, and especially to prevent the developing of a post-thrombotic syndrome that, as you know, it's between 18 and 35% in these kind of patients, depending on the different series. But for us, it's mandatory, especially in young patients, because I think that the long life that they have to live could be really reduced in quality of life if we don't do something fast. Okay. After what it's interesting is to know and to see the evolution of the patient in the first 24 hours, because when we have the patient admitted and we start with the heparin, I mean, the heparin is still the gold standard, we know. So it's a treatment that we have to start from the beginning, and from the first moment that we have the diagnosis of a deep vein thrombosis. And sometimes it's interesting to see the evolution in these 24 hours with a compression bandage and with the legs in elevation starting the heparin, because that sometimes is touching a bit our algorithms in time decisions and in knowing when or where to approach the patient. Um, Anticoagulation, it's absolutely mandatory. I think that there is not any reason to don't do it today, even if you plan or not an interventional procedure for a DVT. But there is a lot of things to be in concern. A part of the following the algorithm, a part of the ultrasound, if we see that we have a really extensive implication of the iliac, even the iliocaval segment, we always perform a vein CT just to confirm the affection of the contralateral site or not, just to evaluate if we have any kind of thrombosis in the vena cava, in order to decide if we will make another prevention movement, like to implant a temporary cava filter for the thrombectomy. And if we have this kind in these patients, I mean, you know that we have this mixing of patients that sometimes the acute deep vein thrombosis is lying over chronic lesions that conditioned occlusions or subocclusions, stenosis, especially in the iliac segments, sometimes related to May-Turner syndrome too. So I think that after the thrombectomy, the venogram is really relevant and really important to decide if we will do something else with these veins, with these lesions, because being honest, I found really, really little patients where the acute thrombosis has been absolutely acute, and we achieve a full recanalization of the vein, leaving it clean of any clot. It's difficult because in the natural way of the disease, the clotting is forming for the ecstasis. So when we have the occlusion, probably the nature of this clot is evolving from many few days ago. But this is something that you learn with experience. And regarding length, in our approach, we try to go as far as we can. I mean, if we plan to go for a catheter interventionist. Uh, we try to go always access distally as possible to get as maximum the full evolution of the veins regarding the inflow, for a future stent or a future device that we can or not implant. And we always try to clean, and we always try to be inside the IFUs of the different devices. Sometimes it's quite difficult because you have to risk a little bit more. But basically, I think that the idea and the concept always is to discharge the patient from the maximum charge of clotting as possible. And usually this is more than enough restoring the flow. And after the heparin and the plasmin is doing their work, and the patient is really well recovering. So this is more or less our way to treat it. And I think that it applies a little bit for what we have in the actual guidelines. But guidelines are guidelines, and then the clinical experience and the clinical scenarios are quite different. So you have to be and to have flexibility, and you have to move regarding what you have in front.
Okay, thank you so much. You basically answered also to another two questions that I had. So thank you for that. I know time is running. I know that operating room is waiting for you, is calling you. So I would just move to the last question, which is, kind of friend to friend question.
Mm.
Some people will hurt, but don't worry about that. My question would be. If you start your career today, okay, what would you do differently? I mean, would you do exactly the same that you did, or something would be different?
Uh, well, the problem is that if I start my career today, knowing what I know today, probably I will do few things different. But I don't regret anything at this point, Luca, because I think that I always try to go forward. I always try to go ahead, to keep learning, to keep uh, be information, be informated for the best of my patients. And I think that this is a little bit the key, and always putting passion in all that you do. And I think this is the basis to go on. So probably regarding this, I will change. I will change nothing. Um, I will say that I will choose the same specialty because I really love vascular specialty and vascular surgery and vascular disease. And I love my profession too, because I always want to be a doctor. I like to help people. I like I love this profession that sometimes, or today, it seems is not as valued as it deserves. I think it's my thinking. And probably, maybe, I will try to learn faster, and I will try to make read more, or I will try to study more. But in essential, probably I will repeat practically the same way that I did.
Thank you for your really honest answer. So no plastic surgery and no other places in your answer. So that's
No.
great. Maybe my answer would be come in Marbella and work there, because I saw a lot of pictures and videos from your place, which is amazing.
Yeah,
So thank you
well,
for being here
maybe
and thank you
maybe
for the
maybe
time.
I will move to Marbella sooner too if I knew it before. Yeah, yeah. Well, it has been a pleasure, Luca. Just to um, say thank you to you for all your work, for your passion. We have a special connection in this sense from the first time that we met. And I wish you all the best. And I'm sure that this Venice 2026 is going to be a really very, very big success.
Yes, we will rock. So, thank everyone for watching this Road to Venice with Ruben Rodriguez Carval. If you want to talk with him directly with no filters, come to Venice. So, thank you.
Thank you. Bye.